Let's go ahead and get started. The question related to nitrous oxide, the question was that nitrous oxide has such a rapid onset of effect, why don't you use nitrous oxide for anesthesia? And the answer is we do to a point, but the problem with nitrous oxide is it's not potent enough to cause anesthesia in animals. We're going to compare potencies during this hour, but the short version is that in order to create anesthesia with nitrous oxide in animals, you have to put them in a hyperbaric chamber so you can give them an overpressure of nitrous oxide to get the level of the anesthetic. And that's obviously not very practical to do. So there's the onset of action, the rapidity of changing the depth of anesthesia, the rapidity of induction and recovery, which is primarily related to the solubility of any given inhalant in blood. And then there's the secondary topic with potency. And they're separate to a degree, although during the induction phase, they combine somewhat because there's the question of how fast the tension of anesthetic gas in the brain rises, and the secondary question is how high a tension you have to cause anesthesia. So there's a rapidity of onset, rapidity of recovery question, and there's a potency question that we'll get to during this hour. We talked last time, we finished up talking about cardiac output, and we said that in a really high cardiac output state, induction is prolonged. And this is a graph that talks about that or shows that. This is going back to an older agent, again, halothane, but it was a little more soluble, so it makes the point a little bit better. This line is a 2 liter per minute cardiac output. This line is a 6 liter per minute cardiac output. This line is an 18 liter per minute cardiac output. And so as cardiac output increases, the rate of rise of the inhalant slows. The primary reason for that is in a high cardiac output state, as we talked about at the end of last hour, we're perfusing a whole bunch of tissues, and we don't care whether we're delivering anesthetic agent or perfusing those tissues or not. We just want to perfuse the brain. It's the only place we really want inhalant. We want it in the brain, we want it in the spinal cord. So in a higher cardiac output state, it takes longer to develop an alveolar gas tension. Therefore, it takes longer to develop a brain gas tension, and therefore a longer onset of action of the inhalant. Other things that I think are a little perhaps more intuitive, if you had a shunt, if you had a tetralogy of flow where you had pulmonary stenosis and you had minimal pulmonary blood flow, I think it would make sense to you that it would be hard to anesthetize that patient with an inhalant technique, and you might in that instance favor more of a injectable technique than an inhalant technique. The third factor associated with uptake of inhalant from the lungs into the blood is the alveolar to venous gas partial pressure difference. At the beginning of anesthesia, there's no inhalant in the arteries, there's no inhalant in the blood. And so as the alveoli fill with the inhalant, there's a pretty good pressure gradient from the air in the alveoli into the blood. As the gas starts to equilibrate, we start to see the level of inhalant in the venous blood returning to the heart and therefore going to the lungs increase. And as that increases, the partial pressure difference between the alveoli and the venous blood decreases, and therefore uptake slows. So there is a pharmacologic reason for uptake to slow as the anesthetic progresses. Other things to think about is if you had pulmonary disease, if for some reason the alveolar capillary membrane was thickened, whether that might be pulmonary edema, whether that might be an exudate, whether that might be emphysema, fibrosis, that would slow the onset of action of an inhalant and perhaps make it more difficult to maintain anesthesia with an inhalant because of diffusion properties or difficulties in diffusion across the alveolar capillary membrane. So now we've developed a level or a tension of the inhalant anesthetic in the blood, rather. Now we have to get it to the brain. And there are a series of factors associated with that. Blood flow to the tissue is a primary one. Solubility of gas in the tissue, and then just like we talked about, alveolar to pulmonary blood, partial pressure differences initially, there's a gradient from the blood to the tissues. The blood flow groups, or the blood flow to the tissues, or the density of capillaries per gram of tissue is another way to look at it from an anatomic point of view. There are basically four groups in the body. One's the vessel-rich group, the vessel-moderate group, the fat group, and the vessel-poor group. Thankfully, our target organ, the brain and the spinal cord, is in the vessel-rich group. Fairly dense capillaries, a pretty consistent and relatively high blood flow for delivery. Other things in the vessel-rich group would include the viscera. We don't really care about the viscera from an anesthetic viewpoint, at least the inhalants, but a fair amount of blood flow goes there. The vessel-moderate group is primarily made up of muscle. Depending on the body state, if you're exercising, you have a higher blood flow to muscle. At rest, muscle blood flow is relatively low. But even with relatively low muscle blood flow, that's a pretty big sink, if you will, for the inhalant to get built up in, and it has a high enough blood flow to make a difference to the induction and recovery from most anesthetics. Third is the fat group. This is April the pig. She lives in Grove City. She comes in to get her nails trimmed, and we don't paint them for her, but occasionally the owner does, and for cutting their tusks. The fat group, all the inhalants are really soluble in fat, so you'd think it'd be a big deal, but it's not. That's primarily because the blood flow to fat is so low. So in terms of the induction, the fat group doesn't play much of a role, other than if it's a really fat animal like this pig, that fatness might, obesity, whatever, I don't know, pigs can be obese, I suppose, might impede ventilation, and we've already talked about the effects of ventilation on onset of induction with inhalant anesthetics. So the amount of fat isn't a big deal with regard to induction. If you had an animal anesthetized for a prolonged period of time, so you had time for the inhalant to equilibrate with the fat group, it might slow recovery somewhat. The vessel-poor group are tendons and bone. It's one of the reasons tendons and bone don't heal very well. They have prolonged healing. They don't have a great blood supply. So the vessel-poor group has less to do with the induction of anesthesia than even the fat group might. When we think about the vessel-rich group, going back to the brain, the spinal cord, and the viscera, the vessel-rich group equilibrates with whatever the alveolar gas tension is in about 20 minutes. So as you set your initial level of inhalant, you might stay there for 20 minutes and see when the brain has equilibrated with what you're delivering or what's in the alveoli, whether or not you need to change the level of inhalant at that point in order to maintain a safe plane of anesthesia. The vessel-moderate group doesn't equilibrate for like 4 hours. So if you have something anesthetized for 4 hours, you might, at that point, well, you're constantly reevaluating, but at that point you might think, well, we've been here 4 hours. Do we really need this much of inhalant at this point? Make an adjustment or think about it. The fat group, it's estimated that it equilibrates in 30 hours. Hopefully you won't have something anesthetized for 30 hours. And people, occasionally they do if they're doing bilateral renal transplants or total liver
those sorts of things, they might have somebody anesthetized for that long. I think about 8 hours is my tops for anesthesia, and that is plenty long. When we're talking about equilibration with the entire body, we're talking about days. So there's constant uptake of inhalant anesthetic. I think it's the overall message of this. You can't, as soon as you turn the inhalant off, the animal starts waking up. It's not like you can say, okay, I've been here 2 hours, I can turn the inhalant off, they'll stay asleep for a while. You're talking 5 to 10 minutes on the outside as they're waking up. So they never equilibrate. You got to constantly administer the inhalant in order to keep them asleep. As soon as you disconnect them from the machine, they're in effect waking up. If you have an animal anesthetized and you're prepping it, you've got it prepped up and you're going to move it into your surgery room, you disconnect it from the anesthetic machine, it's waking up for the 30 seconds to a minute it takes you to get it in the room. If the door is blocked and it takes you 3 minutes to get in the room or 5 minutes to get in the room, you're going to have to re-anesthetize it with our current inhalants because that's long enough time for the animal to wake up. So as you go into OP, think about that as you're moving your animal from the prep area into the operating room. You need to have a path clear, you need to have everybody moving together, and you need to be pretty expeditious in getting it done. In terms of the gases entering the brain, that happens relatively quickly. It's not a factor that we consider on a daily basis. If there's a brain there, the inhalants will get there from the blood. Equilibration occurs pretty rapidly, so that doesn't really affect our thinking very much about either induction or recovery from anesthesia. So we anesthetize them to a level that we think is going to be appropriate. We monitor the animal's responses. What's its heart rate? What's its blood pressure? When the surgeon cuts the animal, does it move? Is it deeply enough anesthetized? Well, one of the things we monitor is jaw tone, particularly in dogs and cats. We just sort of press on the upper and lower jaw and see how much force for us it takes to push them apart. It gives us an idea of how relaxed the animal is. If the jaw tone is really slack, if the blood pressure is really low or the heart rate's really low or the animal's not breathing, we might reduce the level of anesthesia or the amount of inhalant we're delivering, see if we can lighten the anesthetic plane and still maintain a suitable patient for surgery. We talked mostly about blood gas solubility and the rapidity of induction and recovery, but there's also a rapidity of changing of anesthetic depth in the middle of the procedure. And for the true drugs that you'll most likely use during your veterinary career, sevoflurane, the depth of anesthesia, if you make a change at the vaporizer with sevoflurane, it happens more rapidly than it does with isoflurane. That change in depth of anesthesia that corresponds to your adjusting the vaporizer. With any of the inhalants we have currently, animal can get too deep in 10 minutes, can get too light in 10 minutes. So monitoring remains the key. This just shows someone feeling a lingual pulse in a dog. If you feel on the ventral side of the dog's tongue, there's two arteries that run lengthwise. Since most anesthesiologists are near the head of the animal, it makes a nice place for you to feel a pulse as one of your anesthetic monitors. Okay, so we've done all the things we need to do to anesthetize the patient. Now we wake them up. And it's easy to wake them up. We disconnect them from the anesthetic machine, or we turn the inhalant off by turning the vaporizer to off. And so what happens then? Well, we're reduce the amount of inhalant we're delivering to the tracheobronchial tree. We dilute out what's in the circle. We dilute out what's in the tracheobronchial tree. The partial pressure of the inhalant in the alveoli falls, so therefore the inhalant leaves the blood into the alveoli, so the level in the blood falls, and so then it leaves the brain and equilibrates with what's left in the blood. So it just cascades out, if you will. The patient exhales the gases, the partial pressures continue to drop. And when the brain partial pressure drops below an anesthetic level, the animal wakes up. In terms of how far does it have to fall for the animal to wake up, it's somewhere around 50% of the amount it took in the brain or the alveoli to keep the patient asleep is the amount or the point at which the animal is going to wake up. We'll develop that a little bit more. Just to reemphasize again, these drugs aren't really metabolized to any significant degree. Metabolism doesn't play a role in where the animal wakes up or not, or the duration of action. The duration of action is controlled by you administering the gas, and when you turn it off, the animal starts to wake up. Metabolism is just very small in terms of its effect. Need to develop a little bit more the potency question that we talked about at the beginning of the hour. The inhalants are compared using a system that looks at the minimum alveolar concentrations of a given inhalant in order to compare the potencies between different agents. This is done primarily in a laboratory. It's done by measuring the alveolar concentration and stimulating the patient. And so the standard for the minimum alveolar concentration is that concentration that prevents movement in 50% of the patients or animals. It's a standard stimulus that's applied, and so you essentially bracket different alveolar tensions until you find the one where about half the patients move. The higher the minimum alveolar concentration of inhalant, the more you have to have in the alveoli, the lower its potency. We like to have a minimum amount of the inhalant in the alveoli in order to cause anesthesia, because that leaves us more room for oxygen and other gas. MAC is somewhat species specific. The minimum alveolar concentrations of all the gases we talk about are lower in people than they are in animals. Probably because we have more cortex. Within a species, MAC is pretty reliable, pretty constant. The duration of anesthesia doesn't affect it. If you do a MAC determination 1 hour into anesthesia, and you do another one 4 hours into anesthesia to see if it's the same, it's pretty much the same. If you hyperventilate the patient and lower its PaCO2, the MAC stays the same. Hypoventilation, if you allow the CO2 to rise, if it gets above 90 for arterial carbon dioxide tension, you have some anesthetic effect at that point. But if you're in the physiologic range of 40 to 70 millimeters of mercury for arterial carbon dioxide tension, doesn't really affect MAC. And between males and females, MAC stays pretty much the same. MAC is altered by age, so it's reduced in older animals. Probably because cortical density or the number of neurons in the cortex is reduced as you get older. MAC's reduced by hypothermia. If you get an animal in the range of 90 to 92 degrees Fahrenheit, you don't need much inhalant anesthesia to keep the patient asleep. One of the things we'll talk about when we talk about monitoring is that most animals get cold with inhalants, and so it's one of the things, or any of the anesthetic agents actually. So we watch their body temperature and we adjust the amount of inhalant or any other agent that we're delivering based on that, and we also apply external heat to try to keep them warm. If we administer other drugs like the narcotics or the opioids to provide analgesia, that reduces the amount of inhalant we need to keep the animal at a surgical plane of anesthesia. And then a disease like hypothyroidism that lowers catecholamine levels across the body would reduce the amount of inhalant that would be required. So MAC's pretty constant between animals, between species or within species, but there are things that can reduce the amount of inhalant required or the potency of the inhalant. It's important to remember that the minimum alveolar concentration is not surgical anesthesia. If you tried to do surgical anesthesia at a MAC level, half the patients would move. So that's not what we want, obviously. But if you think about how much more than MAC you need to cause anesthesia, it's about 1.5 times the minimum alveolar concentration that approximates surgical anesthesia in most patients. So MAC is a laboratory thing. It's a way to compare inhalants. But in terms of us using the inhalants on a daily basis, it tells us, for example, since sevoflurane is less potent than isoflurane, it tells us that we need a higher vaporizer setting of sevoflurane in most instances. Any questions about the general principles of the inhalants we've talked about? Well, we'll try to apply those things then to the drugs. First drug we want to talk about is diethyl ether. It's a little bit of a historic drug. It was one of the first inhalants. It's a great analgesic at relatively low concentrations. It produces really good muscle relaxation, really minimal respiratory depression, in part because it irritated the respiratory tree somewhat, minimal cardiovascular depression. The two drugs that we use currently, sevoflurane and isoflurane, are halogenated ethers. So they're modifications of diethyl ether, and the reason that they're used is that they're less soluble in blood, as we talked about, but the biggest thing is surgeons like to use cautery. And diethyl ether is explosive. In fact, if you use diethyl ether, you put conductive strips on the bottom of your shoes because even the spark from static electricity in the room could cause diethyl ether to explode. So that was a problem in operating rooms, particularly when surgeons started using cautery. Other things is they had a relatively slow induction and slow recovery, but in the 50s and 60s, they had diethyl ether and one other agent that we're not going to talk about, which is cyclopropane. Caused nausea and vomiting, but again, flammable and explosive in modern operating rooms are really two things we can't deal with very well. Diethyl ether is still used occasionally in laboratory animals. It's used in laboratory animals because it has a really slow induction and a slow recovery. And it's not very soluble, or it's not very volatile, I should say, excuse me. The maximum concentration of diethyl ether that you can deliver is not enough to rapidly cause death. So you can put a little diethyl ether on a piece of cotton, put it in a jar with a rat, watch the rat slowly go to sleep. When the rat's asleep and breathing but not moving, you can pick the rat out, you can draw blood, you can biopsy something, and the rat will slowly wake up. But that's primarily the only place it's used for anesthesia. It's also used as a solvent to sort of defat the skin and make bandages stay on better. That's the primary use in our hospital at this point. We talked about nitrous oxide a little bit in our last session. Nitrous oxide is different from the other inhalants in that it's a gas at room temperature. You buy nitrous oxide in a tank. It's compressed at 750 psi. In this country, it's in a blue cylinder. High pressure cylinder stored at 750 psi. Nitrous oxide itself is non-flammable, but in the presence of heat, nitrous oxide decomposes into nitrogen and oxygen, so it will support the combustion of other material. Nitrous oxide in and of itself has minimal cardiovascular effects. It's a nice drug from that aspect. The animal has good blood pressure, good cardiac output, may even increase a little bit over the resting state. They breathe well. Has a very fast onset of effect and recovery because it has a low blood gas solubility ratio. Things that we've talked about in the last hour. So if you look at nitrous oxide, whoops, sorry. There we go. Nitrous oxide, it has the fastest rate of rise. We'll look at a series of these graphs over the other agents, or we'll repeat this graph. So this is the amount that's being delivered to the patient. You can see that within 10 minutes of the beginning of delivery of nitrous oxide, you're almost at 100% of what you're delivering. Very insoluble, rapidly rises. At 20 minutes, you're at 99% of the amount that you're delivering. That's as fast as we have. But by itself, it cannot produce anesthesia. The MAC that we talked about would be 180 to 200, which is unattainable at normal barometric pressure. And if we tried to have an alveolar concentration of 180, we wouldn't have any room for oxygen, and we'd be hypoxic anyway. To have any effect at all, you have to deliver nitrous oxide in 60 to 70% of the inspired gas mixture. That supplies about a third of a minimum alveolar concentration, which you can add to isoflurane, so you can combine nitrous oxide and isoflurane and reduce the dose of isoflurane a little bit, or reduce the dose of sevoflurane a little bit. But it's not worth it. The reduction in the dose of sevoflurane and isoflurane is not worth the cost or the hassle that it takes to administer nitrous oxide. Problems with nitrous oxide include that you have to reduce the amount of oxygen you're delivering. Normally, we're using oxygen by itself as a carrier gas, and so we're delivering somewhere around 95% of the inspired gas as oxygen. If we use nitrous oxide, we're reducing the amount of oxygen we're delivering to the 30 to 40% range of the inspired gas. That's enough to oxygenate most patients, but there's a little less of a safety factor associated with that. Other issues for nitrous oxide is because you're giving it in such a high tension or concentration, it tends to diffuse into closed gas spaces. So in a cow, that'd be a ruminant, or a rumen rather. If it was a dog that had gastric dilatation and bloat, the nitrous oxide would diffuse into the bloat and make the size of the balloon in the animal's stomach bigger, or it would raise the pressure within that, within the stomach if it couldn't get any bigger. The third issue with nitrous oxide is at the end of anesthesia, as all the nitrous oxide is rushing out, you have the potential of diluting the amount of oxygen in the alveoli, and you get a factor that's called diffusion hypoxia. Now you can offset that by supplementing oxygen for 5 to 10 minutes in order to maintain oxygenation. But again, it's a safety factor, and the question becomes, does nitrous oxide add enough to make its use worthwhile? And most have said no in veterinary medicine. Okay, we've talked about nitrous oxide, we've introduced diethyl ether. The rest of the inhalants that we're going to talk about can produce anesthesia by themselves. When we talk about anesthesia, we talk about hypnosis or sleep, we talk about analgesia, we talk about muscle relaxation, we talk about reducing the reflex activity, so that if the surgeon cuts the patellar tendon, the patient doesn't kick or hurt. The most commonly used inhalant anesthetic in veterinary medicine is isoflurane. How many have seen isoflurane used? Most everybody. It was originally sold as Air. Now it's a generically available drug, which has lowered its price considerably, but I don't think any veterinarian would tell you that isoflurane was cheap. But it's cheaper than sevoflurane, but it's still not cheap. Isoflurane is pretty volatile inhalant anesthetic. It has a vapor pressure, as we said last hour, of around 250 millimeters of mercury. And so we can attain a maximal concentration from isoflurane of about 33%, which is tenfold in excess of what we need to cause anesthesia. So again, we need to control that vaporization. Isoflurane is pretty potent. The minimum alveolar concentration of isoflurane is about 1.5 in a dog. So if you got 100% of gas in the alveoli, if 1.5% of that gas in an alveolus is isoflurane, the patient will be at a MAC level. Remember, if we on surgery level, we have to multiply MAC by 1.5 or so. So if we have 2.5% of the alveolar gas is isoflurane, that animal's asleep and pretty close to a surgically anesthetic plane, or most of them will be. Again, there's always individual variation. We always have to monitor that. Isoflurane produces pretty fast induction and recovery. Its blood gas solubility ratio is 1.41. If we look at that back to our graph again, the arrow points to isoflurane. So the rate of rise of isoflurane toward the inspired concentration here at 1 across the top. If you're at 20 minutes with isoflurane, you're at approximately 70% of the inspired tension. So that's pretty rapid compared to the other inhalants that we used to use. Certainly it's manageable. If we talk about the induction agents that we use, and let's take a typical dog. We sedate it perhaps with acepromazine and some oxymorphone or another opioid. We bring it in, we place a catheter, we might give it a bolus of propofol to induce anesthesia. That bolus of propofol is going to last in most instances somewhere between 15 and 25 minutes. So it's a race between that propofol wearing off and the rise of the inhalant to an anesthetic level. So basically you have to, is anybody counting basically? I'm sorry, I'm keeping going. You have a race between the induction agents wearing off and you establishing a level of inhalant anesthetic that will keep the patient asleep. Isoflurane causes decreases in blood pressure. It's a pretty potent vasodilator. Causes some decreases in cardiac output, but in terms of the level of depression, it's clearly safe for the patients. So you administer isoflurane, blood pressure is going to go down, heart rate may go down, although the effects aren't always predictable, and cardiac output goes down somewhat. The decreases are dose dependent. So the more isoflurane you give, the lower the blood pressure is going to be. And so if you can't balance the level of blood pressure with the level of isoflurane that's required to produce anesthesia, sometimes we lower the level of isoflurane and add other drugs like an opioid to augment analgesia and see if we can reduce the isoflurane requirement somewhat. In terms of respiration, isoflurane reduces respiratory rate, reduces minute volume, and tidal volume as well. In small animals, respiration usually remains within acceptable limits. In a dog, the arterial carbon dioxide tension in a dog anesthetized with isoflurane, normal dog, might rise to 50 to 55 millimeters of mercury. In large animals, they don't breathe very well under anesthesia. Most horses that you anesthetize with isoflurane or sevoflurane as well, the arterial carbon dioxide tension is going to rise to the range of 60 to 80 millimeters of mercury when they're surgically anesthetized with isoflurane. So small animals, respiration is pretty well maintained. Large animals, respiration has to be supplemented or you have to control ventilation in most instances. Isoflurane is not really metabolized at a significant level, less than 0.5% of an administered dose. So again, most of it's exhaled and leaves your building through your scavenging system. Isoflurane is the most widely used inhalant in small animal practice. it is all in large animal practice because one of the halothane used to be more widely used in large animals, but it's no longer available in the United States. If you go to Australia to practice and you want to do horses in Australia, halothane's available there. But there weren't enough people buying halothane to keep it on the market in the United States. So our key points for isoflurane is pretty quick induction and recovery, minimal cardiovascular depression, cardiac output's pretty well maintained, although blood pressure goes down. Moderate respiratory depression, we worry about it more in large animals than we do in small. Because it's a halogenated ether, it causes pretty good muscle relaxation, and on a comparative basis, it has really minimal metabolism. Second agent that's in common veterinary use is sevoflurane. How many have seen sevoflurane used? A smattering, I'd say. Half a dozen, a handful, maybe a dozen. Sevoflurane is a newer agent. The patent is off or coming off sevoflurane, but it's still about 4 times as expensive as isoflurane. The exotics people, in exotic medicine, a lot of times you use mass induction because you don't really want to give animals drugs that they have to metabolize. So the exotics people went from, when sevoflurane first came out, they sort of adopted it, and then they backed off sevoflurane, went back to isoflurane, and now it's sort of a mixture between the two of who uses sevo and who uses iso. Both are safe. It's a rapidity of induction question. And the other question is the level of respiratory depression. We'll talk about that here in a minute. Sevoflurane is less soluble than isoflurane, so it produces extremely fast induction and recovery. Its blood gas solubility ratio is about 0.65. And so if you look at sevoflurane in our recurrent graph here, the arrow, the arrow on sevoflurane at 20 minutes puts the alveolar gas tension at about 80% of the inspired level. So again, if you think about the transition between induction with an injectable drug that's going to last 20 minutes and the inhalant, you have plenty of time to get a level of sevoflurane on board to keep the animal asleep once the induction drug wears off. Sevoflurane is less potent. That's the other primary factor with regard to the amount we have to deliver to think about. Its MAC is 2.4% in dogs. That means you need for induction a vaporizer setting of 5 to 7%. And you need to maintain the patient usually somewhere between 3 to 4% on your vaporizer setting. If you go back to what the 1.5 times MAC would be, what would that be? 3.6% for sevoflurane compared to what, less than 2% for isoflurane. So not only is it more expensive to buy, you have to use a higher concentration, so it's more expensive to use. Vapor pressure for sevoflurane is 160 millimeters of mercury, so you need a specific vaporizer. You can't use an isoflurane vaporizer for sevoflurane. You can't use a sevoflurane vaporizer for isoflurane. When they initially started selling sevoflurane, they gave you a vaporizer if you agreed to buy so many bottles of it. In terms of the cardiovascular and respiratory effects, they're pretty close to isoflurane. They're very, very similar drugs. They're different isomers almost they're different. Isomers is the wrong word, but they're different. They got different atoms substituted on diethyl ether to get the non-explosive factors and the solubility factors that we talked about. One of the differences between sevoflurane and isoflurane that cause some people to want to use sevoflurane is that sevoflurane is reportedly more pleasant to breathe than isoflurane. Particularly in people cough with isoflurane, they might sneeze, they might have increases in secretions in the respiratory tract. Sevoflurane, people think it's more pleasant to breathe. To be honest with you, I think the odor of sevoflurane is more obnoxious than the odor of isoflurane, but I don't know if the animals have a personal preference. So if you want really rapid induction and recovery, if that's important to you, you might want to pay the extra money and do sevoflurane. If our techs are anesthetizing a colic in the middle of the night, they usually use sevoflurane because it might cut the overall duration of recovery from 50 minutes to 40 minutes, so you can go home. Again, I think its sort of popularity is wafted back up in exotic practice. Anybody hang out in exotic practice? Sevoflurane, isoflurane?
We use dicel.
Use dicel. Anybody seen sevo used in exotic practice? You can produce safe anesthesia with either one, so at some point it comes down to personal preference, and when you're spending the money, you can have all the personal preference you want. Sevoflurane, initially there were some concerns about its toxicity, things that it reacted with, perhaps metabolites that might be a problem, but they've pretty much been sorted out, and it doesn't seem to be an issue in clinical practice. If you give odd concentrations of sevoflurane to odd animals, occasionally you'll get a toxicity, but that's in a pretty severe circumstance, and we've adjusted the other things that we use in combination with inhalants in order to compensate for that. Sevoflurane is metabolized minimally. It's more than isoflurane, but it's still in the range of 3 to 5%, so that's not significant. Metabolites aren't significantly toxic. So our three key points for sevoflurane: extremely rapid induction recovery. Sometimes they wake up too fast, particularly in horses. Sometimes we resedate them in the recovery stall to slow them down somewhat. Cardiorespiratory effects are not identical, but very close to isoflurane. I would argue in large animals that sevoflurane is somewhat more of a respiratory depressant in my personal observation, but the research doesn't necessarily show that. And it's very expensive, about 4 times isoflurane. A couple other inhalants to talk about because they're out there, and as you read AJVR or the Journal of American Veterinary Medical Association, you may see articles about these. Desflurane is a halogenated ether. It's used in people pretty widely. If you're anesthetized at this point, you're probably anesthetized with either sevoflurane or desflurane. Very insoluble in blood. Boiling point at or near room temperature, which makes it a little problematic for a standard vaporizer. And so they have to have a heated vaporizer in order to, essentially when you heat the vaporizer, you make the desflurane a gas all the time at the temperature that's in the vaporizer, so you can then control how much you're delivering easier. So that means you got to have it plugged in the wall. So for us, if you're running from small animal surgery down the hall to radiology, the vaporizer won't work as long as it's unplugged from the wall. You got to look for an electrical plug and wait for it to heat up, all that sort of stuff. So it's not really very practical in most veterinary settings. Got to be plugged in. The other piece is that it's really expensive, even more than sevoflurane. Go to work for some old guy like me, he might talk to you, or she might talk to you about methoxyflurane. Methoxyflurane was once the most popular inhalant anesthetic in small animal practice. It's no longer made in the United States. I don't know that it's made or used anywhere to any great degree. It's not very volatile. The maximal concentration you could produce was about 3%, and it was very insoluble, so it had a very slow induction and slow recovery. So it would work in the situations like we talked about with diethyl ether. If you had a cotton ball and a rat in a jar, you would slowly anesthetize the rat, take it out, do what you needed to get done, and let it wake up. That's the only time that I know of methoxyfluorine used with any frequency. One of the beauties of methoxyfluorine is that the onset of action was so slow that it's hard to get enough methoxyfluorine in a short duration to cause death. So from that aspect, it was relatively safe. A little perverse, but true. The other agent, the last one to go away, the one that I miss on occasion, is halothane. Halothane had a volatility similar to isoflurane, so you had a maximum concentration of 33%. It was very potent, more so than either isoflurane or sevoflurane. Blood gas solubility was a little higher than those two, so its onset of action wasn't quite as fast, but it was manageable. And the thing that sunk halothane as an inhalant is that animals were more likely to have ventricular arrhythmias with halothane. The halogenated hydrocarbon rather than the halogenated ether. So it's caused some myocardial irritability, which is a factor in dogs and cats and people, but not so much in horses. Worked really well in horses. Horses just don't get ventricular arrhythmias very often under anesthesia. I mean, 12 times in 30 years, something along that range, isn't very often. Halothane, because it lost its use in small animal practice, there wasn't enough of it sold to make it worthwhile to keep manufacturing, so it went away unless, again, you're in Australia or some other parts of Asia. Been gone since 2004. Questions?